is it that sometime in between people were little reckless or something?
Naturally. See, the indiscipline is one of the our in blood.
Correct.
We can't.
Sorry to interrupt. Vinay, do you want our mics to be mute if we are live right now?
It's okay, sir. Generally, you can talk, sir. Generally.
Okay. Okay. Yeah.
Hello.
Are you live or you are going live after 5 minutes? You told.
We have started letting the attendees in, sir. People are joining in now.
How many people joined?
Around 16 people have joined now.
Okay.
We'll just give 2-3 minutes time and we can start.
There are multiple webcasts at same time, 6 o'clock.
Oh, yeah. Vinay, can you resend to Dr. Shrikant the link? He is asking for
Yes.
to resend it.
Yes.
And maybe you can just ping him on over phone.
Yes, sir. Yes.
Even in Alkem also we have two different divisions webinar today.
Alkem's own webinar is also going on.
And Alkem's own HR webinar is also going on. So too much digital we become nowadays.
So Kapil.
Yeah.
Hi, how are you?
Fine, absolutely fine. Rushing around.
So Pune must be busy now.
Yeah, it's quite rush hours.
Yeah. I'm going to speak on your topic actually.
Yeah?
I'm going to speak on your topic about...
Not my topic.
Yeah. So it must be very busy. Ki, what is being...
It's very busy. It is extreme busy. We are overflooding. We are at 200 capacity in my hospital. We are going to the soon needs to 300 to 400 anytime. And we have to stop now non-COVID if it continues like that. That's the issue. So
non-COVID will have to stop for a month then because
I think but then the corporation will make it sure that we will increase the bed. So naturally it will go down.
When what will happen now? You will have for next 1 month only COVID.
Yeah, ideally, I cannot put the non-COVID into the risk with such because alternate strokes are coming positive, alternate traumas are poisoning. Even every alternate, there is no disease pattern. It is not related with the COVID. They are asymptomatic carriers.
So here, what we did in Global Mumbai, we had a COVID dedicated ICU, COVID suspect ICU, and then the clean ICU.
Yeah.
Similarly,
we have same. We have same. But unfortunately, load is so much. It is now there is hardly any line of demarcation in between suspected and positive.
Correct. I agree with you.
Yeah. That's the issue. So this is all these demarcations and the separation was fine 2 months back. Correct. But now I told you, even poisoning patients are coming positive. Probably either they are hiding history or it is a asymptomatic carrier or this. I don't know, but almost out of 10, 8 poisoning came positive. There's nothing to do with COVID. But now, then how to define which are non-COVID and which are COVID? This is very difficult.
So unless you have that TrueNet in the hospital, where TrueNet will give you whether the patient has coronavirus or no coronavirus.
Exactly. But it's very difficult. I told you that the line of demarcation is completely lost. We are doing each and every stroke, RTA, which are going for the imaging HRCT as a compulsory. If there is a GJOs, shift to the isolation, do swab.
Then if you try
patient from GJOs on HRCT.
If you have a triage corona TrueNet, I think TrueNet is that which just detects corona is there or not. It could be community acquired corona also.
No, even last week we started the antigen test also.
But that is only 50%.
Yeah, but again, at least you can have some high suspiciousness.
Antigen plus CT you can combine and
yes. But I told you, there is no demarcation now. Even the reports are negative, but clinically they are sure corona, you cannot shift them. The reports are coming positive on third, fourth swab attempt.
Yeah, patients will come to day 7.
Yeah. Sorry to interrupt, doctors. Very sorry to interrupt. Vinay, are we getting live?
Yes, sir. We can start.
Okay. Yeah, Mr. Sandeep, can you start the proceedings? Mr. Sandeep, we are live and we can start.
Yeah. Good evening, doctors. On behalf of Alkem, Hospicare, I welcome all our faculties. Especially, I'm very thankful Dr. Kapil Jirpe for giving some time to agree to be a chairperson and moderator. Dr. Basant to be a speaker on sepsis and management. And then Dr. Amitabh Saha, Dr. Apurva Bora, and Dr. Srikant Pattu to be a panelist. I also welcome all the audiences, all the eminent audiences who are attending this program. So this is our fourth CRITIQUEST webinar in the series, which we have planned with a very novel molecule which we have launched first time in India called Arbekacin, and its uses in different indications.
Now I am on, right?
So with that, I will request Dr. Hemant from our medical affairs to take the session and to introduce Dr. Kapil Jirpe to start.
Yeah. Thank you, Mr. Sandeep, for the warm words. To set the context of the meeting, I'd like to say a few words about the background of this meeting first. By saying that antibiotic resistance, as we know, is the biggest threat to the global health currently. And that's due from this drug-resistant infections is set to escalate exponentially. Fraternities from the critical care setting, we all know that the pipeline for the new antibacterial is almost empty, and due to which the WHO has reinforced warning to tackle the growing threat of antimicrobial resistance. And as Mr. Sandeep also said, that we are here to present the Arbekacin, which is a novel aminoglycoside. Preliminary for the treatment of MRSA infections, but definitely it has a scope beyond that also. Even though I'm saying it's a novel antibiotic, but definitely it has been used in Japan, Korea for almost 2.5 decades, and it has been approved in India. So with this note, I'm not keeping anybody away from this beautiful scientific discussion on the molecule Arbekacin. And for this, I'd like to introduce Dr. Kapil Jirpe. I think he needs no introduction. He's a well-known, eminent face in the world of critical care medicine. Sir is a director and HOD Neurotrauma Unit, Ruby Hall Clinic and Hospital, Pune. Over to you, sir, for the further proceedings.
Yeah. Thanks for the kind introduction, and good evening to everybody, faculty as well as participant. And as you rightly say, it is not a new it's not a new molecule. Now we have also quite good experience. Everybody's using this molecule. So let's start the flow of the event. Initially, we have the two case presentation by our eminent guests who are very experienced in their field. Followed by, we will have panel discussion, and please write down your questions, and which we'll discuss during the panel discussion. I will try to accommodate each and every question if the time permits. So with this short initial introduction, I request our first speaker, Dr. Vasant Nagwekar. Dr. Vasant Nagwekar is the ID specialist from Lilavati Medical and Research Center. And everybody knows that he's known for the simplicity. He makes the things in simple way to present. And that's what I'm also fond of his lectures. So let's enjoy his experience in a short time with the case presentation. So Dr. Nagwekar, may I request you to start with your case, and then we'll move ahead with our next flow of the event. Dr. Vasant Nagwekar.
Yeah, thanks Kapil for the kind introduction. And today's talk is on sepsis and its management, but I'll be more bolder to discuss about the antimicrobials and the diagnostic part. Rest all is Dr. Kapil's area, which I'm encroaching the intensive care unit. So I'll come to my first slide. I think all of us know that global sepsis burden, we have almost 270 lakhs of sepsis cases, almost 80 lakhs deaths happening across the world. The incidence of sepsis is 16.45% of ICU admissions. Mortality has been reported at 65%, which is the higher than reported, actually at 28-day mortality in patients with septic shock, I would say. Severe sepsis and septic shock, because sepsis is completely, I think that was in 1991 when everybody started talking about sepsis. But all these mortalities are patients who come to you with severe septic shock. I think that is what is the whole thing. And the global program is to reduce the mortality rates and improve the standards of care. So I'll just come to the first, I'll just give you a case scenario, which will help you just to understand what we are going to talk about. Here's a 22 years old man who was admitted to the intensive care unit of this hospital in winter because of hypoxemia and shock. And the patient had been unwell till 5 days before admission, had head congestion, fever with chills, non-productive wet cough, treated with symptomatic treatment like a URTI. 1 day before the admission, he was seen in the emergency department where his hemodynamics were normal, his saturations were normal, and he was sent home on symptomatic line of treatment and his X-ray was normal. He was treated as bronchitis on bronchodilators and sent home. This is a slide where everything starts. Exactly 24 hours later, relatives took the patient back to the emergency department where a day prior, a couple of days prior, where he was treated as, it was diagnosed as symptomatic viral URTI or whatever, given symptomatic treatment and sent home. He comes to the emergency region with cough, shortness of breath, diarrhea, diaphoresis, nausea, vomiting, and he reported no chest pain. Now, this is a case in the last winter, so it is nothing to do with COVID-19. I'm not going to discuss anything on COVID-19. So please do not get mistaken that, this case, what I'm going to discuss is COVID-19. So it has nothing to do with COVID-19. It was last year when there was no COVID. So on examination, he had severe respiratory distress. His temperature was 36.8, slightly on the lower side. Blood pressure was very low. And the pulse rate was 165, respiratory rate was 55, and saturation was 79. So he was in basically hemodynamic instability when he came to the emergency room. His counts were 1,620, platelets were 145, creat was borderline high, the liver enzymes were borderline high, the CRP was very high, the procalcitonin was very high, and the ABG did show that he had hypoxemia with mild retention of CO2, and he had metabolic acidosis also. So he had basically multi-organ failure with leukopenia, with at least the PCD and CRP suggestive of a bacterial sepsis. So, and what went wrong suddenly in this 48 hours for this patient, and this rapid influenza test was negative. So this was the X-ray when he came to the emergency room, and then he had to be intubated and ventilated. So basically coming to this whole thing, when this patient had hemodynamic instability, whether this was SIRS, actually if you see, he fits into the SIRS because except for the temperature, his heart rate was very high, respiratory rate was almost more than 36, 50, PCO2 was high, the WBC counts, of course, were less than 4,000. That is what it showed. So either it has to be more than 12,000 or less than 4,000. He had an infection because he had a PCT which was high, CRP which was high. So it was sepsis. And also he had multiple organ involvement. That is, he had a liver involvement, he had a kidney involvement, and he had hemodynamic instability, and he was in hypotension. So basically from SIRS to septic shock. So these were the 4 definitions which were there in 1991, and it made slight confusion as because there would be a lot of patients who would come as SIRS because of non-infective causes, and like pancreatitis, you would have a patient who coming to with pancreatitis, and you would label as SIRS, and then every SIRS patient, even non-infective, would be labeled as sepsis. So that was a question, that was a problem, that even non-infective patients were labeled as sepsis, and that's why I think gradually 1992, 2001, and then 2016, 18, gradually the guidelines by the intensive care, that is the critical care team, has evolved into over a period of time into much narrower. So we just have sepsis and septic shock now. So this was redundant. So the third international consensus definition for sepsis and septic shock, sepsis 3, which came into the picture. So the older definition was like this: patient suspected infection plus SIRS, plus he had hypotension after, hypotension plus he had hypoxia, and he had bicarbs which were on the lower side, and possibly lactates were also high in this patient. So all this was the older definition, but the newer definition talks about suspected infection, and we know that the infection was in the lungs. He had a high PCT, high CRP, and then his Q SOFA was more than 2 because he was tachypnic, he was hypotensive. So anything which is or SOFA score which is more than 2, I think this is, we'll come to quick SOFA is only 3. We have 3 parameters, whereas SOFA we have 4 parameters, and then we divide it into 1 to 4 grading according to the severity of the scoring system. So here in the newer definition, we just have suspected infection plus any 2 parameters of Q SOFA, which is which fulfills the criteria as sepsis. But if the same thing, the patient is requiring inotropes in spite of adequate resuscitation, then we say that this patient is in septic shock. So possibly this patient was in sepsis and septic shock, and also his lactates were, I think, 4 or 5 when he came to the ER, but that ABG did not show that. So there was a slight differentiation in the older and the newer definition, that a severe sepsis has been removed, and I think it's a clear definition of sepsis or septic shock. So there is no SIRS and there is no severe sepsis in between. So this is what used to happen earlier, clinical case scenarios of sepsis, where patients used to come to with high WBC, high CRP, possible source could be lung, abdomen. There was an infection, there was an organ dysfunction, it was labeled as sepsis. Similarly, you could have an organ dysfunction which could be a non-infective cause, which also could be labeled as sepsis and associated infection. So there was a confusion in this, and that's why that terminology of severe sepsis and SIRS has been completely removed. So this slide also tells you about that trauma, burns, pancreatitis, ischemic reperfusion injury are among the non-infection causes of SIRS. Since inflammation at the molecular level triggered by the infection in clinical terminology has similarities with sterile inflammation, it is difficult to discriminate between the two in the early stages of disease. So even sepsis as well as non-infective causes of increased inflammatory parameters like high blood pressure, low blood pressure, tachycardia, CRP high, high leukocyte count could be seen in non-infective causes. It was becoming difficult to differentiate this. So both infection-triggered inflammation, sterile inflammation activate the coagulation, inflammation, and tissue repair pathways. According to the old definition, sepsis was diagnosed in the presence of SIRS criteria and infection. Thus, the most patients who presented with simple infection also exhibited SIRS criteria, and all infections were diagnosed as sepsis. So that was the drawback of this older 1992 definition. So these are the 4 parameters. I think everybody must be knowing the sequential organ failure assessment score, which talks about the respiratory, the PaFi2 ratio, the platelet count, the bilirubin, about the blood pressure, the mean arterial blood pressure, the Glasgow coma score, and the creatinine. I think 3 and 4 is the one which talks about moderate to severe and severe about the SOFA score. So simplifying further the definition of simplifying the SOFA and the sepsis 3, what was made was sepsis clinical criteria, that is infection plus change in the SOFA, that is any of these two parameters, any two parameters would conclude that this patient is in sepsis. And if the patient requires inotropes in spite of adequate resuscitation in the casualty, and the mean arterial blood pressure is not coming above 65, or if the lactates are high, possibly we would say that this patient has got sepsis with septic shock. So there's no SIRS, no severe sepsis, it is only sepsis or septic shock. So the Q-SOFA does not define sepsis, but the presence of two Q-SOFA criteria is a predictor of both increased mortality and ICU stays of more than 3 days in the non-ICU patients. Does not require lab tests, can be assessed quickly and repeated. So this is a good module for quickly assessing the patient in the casualty or even in the ward, whether this patient requires to be shifted to the intensive care unit or not. So if the sister or the resident doctor finds that the blood pressure is less than 100 or having altered mental status in the ward, or his respiratory rate is more than 22. So any two criteria of this possibly suggest that yes, this patient requires to be at least observed in the critical care unit, in the intensive care unit, and definitely this reduces the mortality, and this is exactly what we're following, and definitely it helped us. Though sometimes it may be a false alarm, but it definitely helps the code blue paging and the critical care physician coming into the ward, quickly assessing the patient. So that has helped to reduce the mortality of a lot of patients in the ward, and some of them may be requiring to be shifted to the intensive care unit will be decided by the critical care consultant or the junior consultant who comes and sees this patient in the ward, or the emergency physician in the emergency department decides on this criteria. So this is a flow chart. Patient with suspected infection. We see the quick SOFA. Is it more than 2? Yes. Assess for evidence of organ dysfunction. Yes. Like this patient who came to us definitely had a Q SOFA more than 2. Then evidence of organ dysfunction. Yes. He had a bilirubin high, creat which was going high. Yes. Does he qualify for sepsis? Yes. And despite, so he received adequate blood, his BP was 55/35. And in spite of giving adequate resuscitation, this patient's blood pressure did not come up to 65. Mean arterial pressure did not come up to 65, and his lactate levels were high. So there was no, so he was non-hypovolemic. So in short, in spite of giving fluid, the patient's blood pressure not coming up, that means he was non-hypovolemic. And there was no reason for this boy, 22 years boy who came just 2 days back, he was absolutely fine, then suddenly coming in septic shock. There's no reason for him to be in hypovolemic shock. To be the reason. So he was adequately given fluids, and that was normally we give 30 ml per kg body weight. Rapidly, normally we give around 1 liter of fluid straight away in the casualty to see whether the blood pressure, whether we can achieve the MAB above 65. And this patient did have serum lactate of 4 or something. And yes, so finally he did qualify for a sepsis plus septic shock. If all this is no, then you can clean. If the further discussion doesn't happen here, it just qualifies for a simple sepsis and without a septic shock. So Q-SOFA score is respiratory rate, mental status, and the blood pressure, which is quickly assessed in the emergency as well as in the ward when these patients and can be salvaged and mortality can be decreased. SOFA variables, we already discussed this about in the previous slide. The various parameters right from grading from 1 to 4, how the severity increases. So septic shock is defined as lactate levels rising more above 2 without hypovolemia and initiation of vasopressor treatment to keep the mean arterial blood pressure above 65. So that is what exactly happened in this boy. Organ dysfunction is defined as an increase of 2 or more sequential organ failure assessment scoring system, and it was determined that this caused more than 10% increase in the hospital mortality. So this patient also qualified for more than 2 SOFA scorings in this patient. Accordingly, when newly developing unexplained organ dysfunction is identified, it should be kept in mind that the patient may be experiencing sepsis, and that's the whole thing. The overall effect of 2016 SSCM and the ESICM task force recommendation is elimination of the concept of sepsis without organ dysfunction, redefinition of the clinical criteria for identifying genuine sepsis cases, and redefinition of the clinical criteria of septic shock. This is likely to improve the accuracy of sepsis epidemiology and hospital coding, and may improve the clinical outcome of this patient. So there'll be less confusion, and it's just sepsis and septic shock. So limitations of SOFA and Q-SOFA is that SOFA and Q-SOFA scores were designed as research tools at a population level to predict which patients with sepsis were likely to die. They do not define sepsis. We should be very clear. They do not define sepsis. It is just they calculate or they give you an assessment that which patients would behave badly and which patients are most likely to go into possibly sepsis, but they do not define sepsis. From where is the source coming and all that, it does not tell you all that. Clinical deterioration in patients with a positive Q-SOFA score may be due to causes other than sepsis. New organ dysfunction should prompt you to consider occult infection. The addition of a serum lactate to Q-SOFA did not significantly change the ability of Q-SOFA to reduce the mortality. So this was a paper in Annals of Internal Medicine which talked about prognostic accuracy of the quick SOFA for mortality in patients with suspected infection. So quick SOFA has a poor sensitivity, but a slightly better specificity compared to the sensitivity when it comes to prediction of mortality. When SIRS was more sensitive, but which was much less specific. Now the 2018 updated Surviving Sepsis campaign bundle of care, which initially spoke about 3 hours, 6 hours, and now it has come to 1 hour bundle. And I think though there was not a consensus in US about 1 hour bundle, but I strongly feel that if a patient has come to in sepsis and septic shock, you have to do everything possible what you can do in 1 hour. That I think I don't believe 3 hours. It should be 1 hour. Everything should be available in the emergency room. And I think everything will come to that, what all things required to be done, how quickly you should be acting in the casualty to definitely prevent the mortality. It is just like COVID patients who come to you with hypoxemia, don't get them admitted to the ward, make the registration, and then give steroids. I think if the patient is hypoxemic and if it's COVID positive, you have to give steroids. Similarly, same principle I'm applying to COVID patients that, we have to have this 1 hour care bundle where we should be acting very quickly into the casualty to prevent morbidity and mortality of these patients. So again, this updated bundle of care said that measure lactate levels. So you should have an ABG machine, preferably if possible. I'm talking about in the major cities, the small 2-tier or 3-tier cities may not have the ABG machines and all that in their casualty, but I think they can go clinically quickly act on the SOFA parameters and take the decision. So measure the lactate levels, re-measure if initial lactate is more than 2 after resuscitating the patient, because many times because of the hypotension, hypovolemia, microcirculatory failure, your lactate levels can go high. So I think after resuscitating, you should reassess the ABG or the lactate level, whether it is improved or not. Obtain blood cultures prior to administration of antibiotic. And this is exactly what I want to tell you, that you have to be everything ready into the casualty, that you have to have multiple blood cultures bottle available. The moment the patient comes into septic shock, after resuscitation, within quickly you resuscitate, assess the patient, resuscitate the patient. You have to draw blood for blood cultures. And most important thing is, depending on most likely whatever, if you seeing the site of infection, you should start with a broad spectrum antibiotic. It could be the chest, or whether it's the abdomen, or whether it's the urinary tract, or whether it is meningitis. I think you'll have to assess, at least have some clinical judgment, because before you say broad spectrum antibiotic, if you give piperacillin, tazobactam, if the patient has got meningitis, it will not work. So it's very important to at least come to somewhere clinical examination and clinical diagnosis before you push into the antibiotics, because whatever the antibiotics you give has to reach the site of infection. That's very important. And only then it will save the life of the patient. Just giving a broad spectrum antibiotic, not reaching the site of infection, will not help the patient to get better. So that's very important. So begin rapid administration of 30 ml of crystalloid for hypotension or lactate more than 4 millimoles per liter. This should happen before doing anything. I think this should be the first thing what you should be starting, even before you collect your blood cultures and starting your antibiotic. I think first thing is to stabilize the patient, resuscitate him quickly, and then you have to draw the blood and then start the antibiotic. So that's why that 1 hour, I think earlier it was 3 hours, but I would say that it has to, even the antibiotics has to be going into 1 hour's time, because that's very, very important. Apply vasopressors if the patient is hypotensive during or after the fluid resuscitation to maintain a mean arterial blood pressure of 65. So after resuscitating, if your blood pressure is still not coming up, you should at least start on with the inotropes and try to maintain the blood pressure above 65 millimeters of mercury. So time zero, time of presentation, is defined as the time of triage in the emergency department or if presenting from another care venue from the earliest chart annotation consistent with all the elements of sepsis or septic shock ascertained through the chart review. So this is the level of evidence. Measure lactate levels, remeasure. I think the same thing what we just spoke in the previous slide. So the 1 hour bundle is that time of zero presentation, measure the lactate levels, obtain blood cultures. I would not agree with this. I would like to say that this 4 should come in 1. I don't know. I'll ask Kapil about this, but this 4th, resuscitation with fluid and starting the vasopressor should be 4 and 5 should be number 1 and 2, and then it should be followed by that. I'll definitely take Kapil's inputs into this because I don't believe that you should first start. Of course, lactate you can measure. Drawing the blood cultures and all that, you can do it later. First, resuscitate. If the patient survives, then you can draw the blood cultures and administer the antibiotics. So most thing is to keep him alive by resuscitating. That's most important. So yeah, I think we have already spoken about this. Yeah. So blood cultures, this is the area of my expertise, and I will tell you that you have to draw at least 2 sets of blood culture. When I say 2 sets of blood culture, means from the right hand 1 set, and when you say 1 set, it means 1 aerobic and 1 anaerobic blood culture, and each bottle should contain 10 ml of blood, aerobic or anaerobic. And similarly, left hand also should have 1 aerobic and 1 anaerobic, and each bottle should have 10 ml of blood. So the total ml of blood total is 40 ml in total 4 bottles. That means 10 ml per bottle. So it will be 40 ml in 4 bottles. So the study which was done in one of the journals, which said that if you send 1 set of blood culture and if the patient is bacteremic, then the chances of picking up is only 60 to 70%. If the patient is bacteremic and if you send 2 sets of blood culture, then the chances of picking up is 90%. If the patient is bacteremic and if you send 3 sets of blood culture, which we normally do in endocarditis, the chances of picking up the organism is almost to the tune of 98 to 99%. But then always the question is, because majority of everybody would say, what is the point in sending blood culture? Because we always get negative blood cultures. See, the chances of when you send 100 patients blood cultures, which are not, all of them may not be bacteremic. So that every lab across the world, only 10% of the cultures will come positive. But those patients who are bacteremic, and if you send 2 sets of blood culture, then the chances that 90% it will pick up those organisms, and you'll be correct in your in your antibiotics if you have not been correct initially at 24 to 48 hours. So administer broad spectrum antibiotics according to the site of infection. So I would say it's very, very important that you identify what is the source, like whether it's abdomen, and most important is whether it's coming from the community or whether it's coming from another hospital after say 5-7 days of stay. If it's coming from the community, then your antibiotic choice will be according to the community acquired problem. Whether if it's a urosepsis, then possibly your cefepime, sulbactam or meropenem should be good, or even ertapenem. If it's an intra-abdominal sepsis, then again your piperacillin, tazobactam or cefepime, sulbactam should be good. But if it's a case of pneumonia, I think it's a 22 years boy. I think I would cover for a gram-negative coverage, and gram-positive means. Gram-positive means I would cover for a methicillin sensitive or methicillin resistant Staph aureus. This boy had a methicillin sensitive Staph aureus bacteremia. Finally, he died in spite of doing everything, in spite of putting him in ECMO. So I think for a community acquired pneumonia, possibly simple ceftriaxone plus maybe a gram-positive coverage would be good. But routinely, Staph aureus is not a common problem in India for a community acquired pneumonia, unless the pointers towards MSSA here was leukopenia. So normally leukopenia is a feature of Staph aureus, but leukopenia also can happen in severe sepsis also. If it's meningitis, I think you have to identify what it is, and if it's meningitis, then possibly I would give ceftriaxone. Plus, I would start him on acyclovir and doxycycline. I think I will not. I would like to cover for rickettsial illnesses also. So that is the way. I think you will have to know what is the syndromic diagnosis, and accordingly you will have to push in the antibiotic. It is just not that every patient you have a fixed antibiotic protocol. I think you will have to at least try to have some idea of what I'm dealing with this patient. Administer IV fluids, I think we already discussed, and vasopressors. Try to, I think CVP is out now. I don't think we do measure CVP. Keeping the map above 60 and trying to maintain the urine output around 0.5 ml per kg per hour is most important. Antimicrobial therapy, as I said, key most important. Now, this is about community sepsis. Suppose if the patient is coming from another hospital who has stayed for 7 to 10 days in septic and septic shock, possibly I would go with a, expecting that this could be most likely a carbapenem resistant organism and upgrade to possibly initially maybe polymyxin based therapy with meropenem or fosfomycin, depending upon the clinical picture. But yes, if it's coming from another hospital, septic shock, till I get my cultures back, because I'll not get time to save this patient. If this sepsis and septic shock has happened in the hospital or in the intensive care unit, then it's very important that to identify what is the cause of this ICU fever, whether is it related to Lyme or is it related to the Foley's catheter which this patient is there, or whether it is related to a ventilatory associated pneumonia because of the endotracheal tube, or is it a hospital acquired pneumonia where he was in the ward and he was colonized, aspirated and developed a hospital acquired pneumonia, or does he have a bed sore or surgical site infection, deep vein thrombosis? So all this common sources of ICU fever. So you have community acquired fever, you have a patient who's coming from another hospital with sepsis, and you have a patient who is in your hospital or ICU developing a sepsis or septic shock. Then it will depend upon what is the syndromic diagnosis. Is it CRBSI? Is it UTI, COTI? Is it ventilatory associated pneumonia? Because your organism would differ from what is the cause of your syndromic diagnosis. For example, enterococcus in the endotracheal tube can never be a true pathogen. Okay, but when it comes to CRBSI or when it comes to UTI, enterococcus becomes a true pathogen. So that's why it's very important that you have to identify what is the syndromic diagnosis before you push in your antibiotics. But before you push in your antibiotics, please see that you have to have 2 sets of blood culture. Source control is very important. If it's any abscess or which is a intra-abdominal collection, percutaneous or surgical abscess drainage, depending on the clinical scenario, you have to do it. Crystalloids, I think I will not talk about this much about because it's completely intensive care and not a infectious disease problem issue at all. But yes, crystalloids 30 ml, we discussed about it per kg. We should push it in 3 hours time. That is almost comes to around a liter or 1.5 liters to try to get the patient's blood pressure up. Inotropes, again, critical care area where I think they use the noradrenaline, possibly second is vasopressin, third is adrenaline and dopamine. Some intensivists prefer to use noradrenaline, adrenaline, and vasopressin, but some consultants you prefer to use noradrenaline, vasopressin, and then adrenaline. We'll listen to Kapil more on this part. So the whole thing is vasopressor when we're using septic shock is to keep the mean blood pressure above 65, and that is what. Steroid therapy, I think there were a lot of yes and no about steroid therapy. Initially they said no, then they said to use high dose steroid, then they said no, not to use steroid. But I think definitely it has reduced the number of ventilatory days and in the number of stays in the ICU. But the infection rate was slightly higher, so there's always a yes and no. But I think those people who are patients who are hypotensive in septic shock are definitely pressure, maintenance dose of steroid and hydrocortisone, either give 50 milligram EW or.
Dr. Nagwekar, sorry to interrupt you. Can we wrap up because in time we need to move ahead for the question answer.
Yeah,
if you don't mind.
I think I'll switch this. We need glucose control important, DVT prophylaxis important, and this is my last slide. When you're treating sepsis, early antibiotics, fluid resuscitation, goal-directed therapy, EGDT is all gone. Vasopressors, insulin to control the diabetes, and I think all this rest supportive kind of line of treatment is important. Thanks for your kind attention on this sepsis and septic shock talk for listening patiently. Thank you.
Yeah. Thank you, Dr. Nagwekar. I know it's very short time to discuss within 15 minutes, but what we'll do, we'll try to answer each and every question during the panel discussion. So it will be easy to discuss about the fluid therapy and the different aspect of the sepsis management. So we'll move to the next without wasting time. The next speaker is Dr. Amitabh Saha. He's from Medical Institute, Kolkata. He's going to speak about the core topic, Arbekacin used in critical care. So Dr. Amitabh, please continue and then we'll go for our panel discussion.
Thank you, Dr. Kapil. It was a nice discussion by Dr. Basant. He has actually outlined how do we manage all the sepsis and septic shock patients. And today my job is just to understand about the new molecule, novel molecule about the arbitacin, and how can we utilize and present and keep this antibiotic in our antibiotic basket, so that we can actually come out with a best combinations of antibiotic with the minimal expenditures, and we can bring our patients come out from the critical situations. Next slide, please. So this is my first case. The 35 years old Indian male presented to an emergency department in a drowsy state with a history of high grade fever for 5 days. The patient gave a history of throat pick in his right hand and a few days previously. Not a known case of diabetic hypertension. He is a non-smoker and non-alcoholic. He works in our own city as a Middletown nursing home. He and his relatives denied absolutely about any intravenous drug uses, and there was no previous history of hospitalizations or trauma other than this throat pick. Next slide, please. This is the picture that all of us can see, that there is a cellulitis which is involved the thinner evidence of the right hand, and there is abscess as well. So we for the treatment management, definitely the first thing is to control the source. So we have taken out the incision and drainage of these patients along with the other conservative management and the supportive care. Next slide, please. Among the systemic examinations, there was the bilateral crackles over the lung fields, he in shock. The chest X-ray shows bilateral diffuse non-homogeneous opacity. Arterial blood gas, there was a type 1 hypoxia. Echo was normal, and the cardiac functions otherwise okay. The ABG shows there was a moderate PaO2 FiO2 less than 200. Next slide, please. This is the X-ray which is showing the bilateral involvement, patchy involvement. Next. So this is the blood parameters on the presentations, and I would like to just show you that there was, other than the TC which was unlikely low, is 2,500 is a low count sepsis, and the SGPTOT was slightly higher. The creatinine on the day of presentation is 1.4 at this young guy. Next. So our diagnosis, working diagnosis of the cellulitis is the septic shock and the ARDS, and we have some pneumonia. Next. This is the CT scan that we did, and ultimately we can see that there is a necrotizing pneumonitis, and there is also some abscesses over there. And we did the echo, and we have ruled out all the features of any endocarditis. There was we also did the esophageal echo. There was no involvement in the heart as well. Next. We have started on piperacillin tazobactam on the basis of our initial hospital policy. And also we have started on linezolid just to take care of the any gram-positive. Next. So the initial, after doing all these things, all the supportive care and the antibiotic therapy, the patient has involved a little bit, but after 2 days there was no such improvement. There was just stagnant of the patient. The patient initially involved, but the patient was staying back. So by that time we actually sent the bronchoalveolar lavage, which was sent during the time of intubations, and that alveolar lavage came positive for the MRSA, which was sensitive to vanco and linezolid. And we also sent for check for the history for the arbitacin, which was as well the sensitive for the MRSA. Now the question is, as the patient is not improving, there was the initial improvement was there. So what should we do? We should change from our ongoing linezolid to something else, or we should add on the vancomycin as well. As not a very good gram-positive in a situation where the patient is in septic shock. So what the literature and understanding that we have, that PKPD presentations of all the amyloid which we will have in our clinical scenarios. Please. Next. So there are other literature also we have. This is the biological efficacy and the safety of the MRSA infections, which if we compare with the vancomycin and the arbitrazine, the literature says that vis-a-vis head-on studies which have shown that the vancomycin and the arbitrazine, the outcome is almost same. Only the clinical efficacy is slightly better in vancomycin, though it is not statistically significant. And the most important another thing which we need to remember during our clinical practice, the post-antibiotic effect of the arbitrazine is much there, which the vancomycin is lacking. Next, please. So this is the another study which has been shown that the bacteriological clearance of any MRSA, if we compare with all the gram-positive antibiotic which we have, which acts against the MRSA like arbitrazine, vancomycin, teicoplanin, linezolid, the bacterial clearance in the systems is actually much earlier in case of arbitrazine rather than when we compare with the vancomycin or teicoplanin. Next, please. And also we know that there are some combination regime of arbitrazine and vancomycin, teicoplanin, ampicillin, sulbactam, which are actually acting as a synergistic and heterodisa and the MRSA stain. The synergistic interactions of the combinations of arbitrazine and ampicillin sulbactam against MRSA, that time kill assay could provide the rationale of clinical use of this combination in the treatment of MRSA infections. That was actually, the study was done in Japan in late 1990. Next, please. So based on this, all the clinical, the informations that we have and gathered for last 30 years, which was actually used in the Southeast Asia, we have actually started on the sensitivity result and changed to arbitrazine 200 mg per day, along with the ampicillin sulbactam of 3 gram IV QDS. We have given all the supportive care according to the sepsis surviving guidelines, and ultimately the patient was improved. The patient was ventilated for 10 days. The patient ultimately, after the extubation, shifted to ward, and we sent the cultures on the day 7, which again came negative, and the patients went home after 3 weeks of staying at home. So this is a case scenarios where, next please, and go to the next case. So this is the case scenario where, other than just jumping on any other one after another, the gram-positive antibiotic, rather than what the novel antibiotic we have, we can actually combining each other and can use on even in these clinical scenarios where the patient can give a very good results to us. I am just going to present in the next case. I am just not wasting the time, because I need to lay out a platform where we can discuss about more of arbitrazines in a panel discussions. So there is another case of female who is presented to us in emergency of 50 years. She was smoker. She was admitted here with the RTA. There was a point of care ultrasound shows there was an intra-abdominal hemorrhage. There was a hemoperitoneum. Patients went to operations, and after the operation theater, successful operation, patient was shifted to our IC. The fluid resuscitations and the empiric antibiotic, which was also went into the operation theater as well. Next, please. So on admission in the ICU, the patient was in shock, and we utilized all the hemodynamic monitoring that we have, including the advanced hemodynamic monitoring. And through that, we have guided our fluid therapy, and antibiotic was going on. The patient was on ventilator, and ultimately the patients came out. We started on the 5% tazobactam and the metrozine, which was started in the operation theater. We continued it, and the patient came out from the ventilator. So we are very happy that the patient now came out. It was a fresh case. The young patients, only she was smoker. So we are very happy and communicated to the patients that the relative that the patients will probably be out of ICU by next days. But on day 3, next please. On day 3, the patient level of consciousness suddenly started to deteriorate. The skin was warm, and the patient was showing all signs and symptoms of warm septic shock. Ultimately, all the parameters and everything that shows that there was a septic shock, and the WBC went up to 25,000. So we sent all the cultures. All the pan cultures have been sent, including the sputum, urine, blood from the channels, and we have started on the empirical antibiotic, and we stepped up from the piperacillin on day 3. Next, please. So this is the day 5. The patient is still not improving. Rather, the patient is further deteriorating on day 5. The vasopressin requirement was increased, and the INR was slightly on DRN state. The INR was around 1.48, along with the D-dimer of 674. TLC was still high with the neutrophil of 90. Focal was 19. And by seeing that the patient was not deteriorated, there was a post-op intra-abdominal operations. Thinking of MDR gram-negative, we have started with the colistin added on along with the meropenem. Next, please. The part culture on day 8, which actually we sent on day 3, that came of the MRSA, which was slightly resistant to the vancomycin for the both central line and the right hand. Left hand shows the MDR Acinetobacter and wound fluid, which shows the bacterial phages. Now we are in dilemma. What an istip that was sensitive to arbitacin for the MRSA. Now we are in dilemma. There are plenty of bacteria. Which bacteria is actually causing the septic shock? We really don't know. Which is the colonizations? We really have a doubt. So we are thinking what need to be done for this patient, because patient is already on meropenem, already on colistin. Though the creatinine was slightly on the high, the creatinine was 1.5, the creatinine clearance was about 35, and the patient was not really improved too much. So look next, please. So we are just going back what the information that we have in our scenario. Also, we have think of using of arbekacin, because the arbekacin is an antibiotic, which is a novel antibiotic, which has a specific anti-activity against the MRSA. At the same time, it has some activities against the gram-negative as well, and especially the MDR Acinetobacter and Pseudomonas. There is a plenty of papers we have known, and this is the paper which has been published in 2006, the susceptibility of the MRSA and to arbekacin, which has not been deteriorated. The sensitivity was almost the same, and when it's compared to the TICO or linezolid or vancomycin. Next, please. And this is again what actually I have told you in the earlier case, that the bacterial sensitivity and the clearance from the system is pretty high, and the viable count of the MRSA, which is cleared very fast when we are using the arbekacin in the right dose. Next, please. And since the arbekacin shows the good antibacterial activity against the gram-negative bacteria in addition to MRSA, some physicians reported to the high efficacy of arbekacin for the treatment of MD or gram-negative bacterial infection, such as Acinetobacter and the Pseudomonas, which was published in Clinical Pharmacology in 2014. So day by the uses of arbekacin is coming into the clinical area, and the physicians are getting more confidence to use it either in single or in a combinations of other antibiotics. Next, please. So there is another paper which is come in 2010, that MJ Duper, that attracted the attentions of the antibacterial against the Acinetobacter baumannii, and which shows that the MIC of arbekacin against the Acinetobacter was less than 8, which is actually a pretty good things to know. And if this MIC is working with the arbekacin, probably it is a very good antibiotic to use against the Acinetobacter. Next slide, please. And this is the scenario where we have to be very careful when there is a creatinine clearance is going down. It is a PKPD study which has shown when the creatinine clearance above 50, the single dose of arbekacin, the arbekacin clearance doesn't much change. But in case of when the creatinine clearance goes down below 50, that arbekacin gets accumulated inside the body and the system, and then that can cause a more renal dysfunction. So we need to be careful whenever we are using the arbekacin in an area where the creatinine clearance is not in a very happy state. But at the same time, we need to understand the arbekacin as it is concentration dependent, and it causes the concentration dependent healing. And whenever we are using once daily dose, so basically trough level, if we maintain less than 2, then probably the renal involvement is much less whenever we considering with the vancomycin. But again, it is difficult for every unit to ask to have a TDM for the arbekacin, but it is wise to have arbekacin when we use the arbekacin in these scenarios where creatinine clearance is not in a very happy state. Next slide, please. There is another published paper which is actually published in just a few months back in 2020 in May. So it has been published from Kolkata, Somaswarkar et al. They have seen plenty of MDR gram-negative bacteria that how arbitacin is working against them. And they have come up with this arbitacin can be used as an empirical choice in severe sepsis as monotherapy or in combination with other antibiotics such as colistin, polymyxin against the MDR or XDR parts. The favorable pharmacokinetics and the dynamics and the spectrums of the drug with the advantage of a single daily dose will make the antibiotic as a handy choice for the management of sepsis with least time of thermometer to needle even in a resource-limited healthcare settings in India. So it's a very encouraging data that we have received just a few months back. Next slide.
Amitabh, can we wrap up because we have quite.
Yeah, it is just. So basically, the treatment now based on these informations, we have started the treatment, and with that we started on switch to arbitacin along with the colistin 1 million just to reduce it down. We withdrawn the meropenem and continued the mentrolin. We given all the supportive cares and ultimately continued the antibiotics for 2 weeks, and ultimately patients go home, extubated on day 7 and discharged on day 25. So these two case scenarios where we use arbitacin, the other antibiotic in a very efficient way, and actually have a favorable outcome even with these difficult scenarios. Thank you very much.
Thanks, Amitabh. It was a quite interesting case, and the most important thing, the case is recovered. So now I will go ahead with the panel discussion. Already I have introduced Dr. Vasan Narvekar as well as Dr. Amitabh Saha. Now the third panelist will be Dr. Shrikant Patro. I'm very happy that surgeon is with us in discussion. Generally, intensivists move around with their own concept of the critical care. So we have one ID specialist, one critical care. Dr. Shrikant Patro is the Chief Consultant Department of Minimal Access Surgical Oncology and Bariatric Surgery from Srishti Hospital, Cuttack. Dr. Shrikant, welcome to panel discussion. You are around?
Thank you, sir.
And then
I'm around.
Good. And fourth one is the Dr. Apurva Kumar Bohra. Is the Head of Department of Critical Care Medicine from Assam. So with this short introduction, we'll start with our panel discussion. And I will get some questions on chat. I will try to accommodate them. To start with, all of us know that what is the current situation across the India. During this COVID, everybody knows that COVID is spread and it is just sitting on everybody's mind and the head. It is very difficult to get out of that for COVID phobia or philia, whichever the word this thing. But I wonder whether our MDR scenarios has been changed because of this COVID, or we are underestimating, or we probably don't have time to look at for these scenarios in our non-COVID, because I always mention in my every discussion, I'm concerned with the non-COVID patients also. In my ICUs, there are the COVID ICUs are full, but non-COVID ICUs are also full. We are regularly getting the trauma, stroke, sepsis patient, pneumonia patient. So what to do about them? We cannot say that the COVID is a priority unless the non-COVID let them die. So with this, this is interesting. Thanks to the Alkem for bringing this discussion of the MDR on the background of the Arbekacin, so that we can get some good explanation from the experts available and the eminent faculty with us. So if you see, there's a MDR overall scenario is changing from India. I know there was a INDICAP 1 happened in 2012. Now INDICAP 2, which is the ICCM survey, which is going to get published this month end, as well as I have one of the co-author for the Moses study where we documented ESBL is 41% and 61 in E. coli and Klebsiella, and MRSA around about 21. But now in 2018, our ESBL jumps to 67 and 74%, and MRSA surprisingly jumped from 21 to 24% to 41 to 45%. So on this background, I find this worth discussing the current scenario. With this background, I would like to go ahead with my surgical friend. I know Dr. Shrikant. How I will see the current scenario in surgical ICUs, and you are being an oncologist and surgical oncologist. What is the current scenarios of MDR infections in your surgical ICU, and which are the prominent, whether the gram positive are prominent or gram negative, or it is a mix, and how you plan your therapy accordingly in your ICU?
Very good evening to all. So this is a COVID era that is making all of us to meet together, because I would not have attended a critical care conferences on my routine basis. So I could become a part to this. So I am happy for that. Regarding this COVID time, for my general perspective, like everybody is not in a bad stage in COVID. Somebody made very good profit in COVID also. So regarding hospital setup, we all been into pressurized, having reduced inflow of the patients, as well as if at all a patient is coming to the hospital, then it is a different perspective that we're dealing to the patient. So that is I'm telling about it is not a metro city where I live now, but if a patient with some sort of fever, even if it is not a acute respiratory illness, but still patient like the staff, the doctors, they are into some sort of fear of dealing the patient. So everyone is in a state of turmoil how to deal a patient, because we have never thought that something like this can happen. In critical care specialty, like surgical cases, if a patient develops fever and with respiratory symptoms later on after a surgery, that also keeps something into mind that it may be a COVID that was previously negative. Now it has come out in a florid one. So now we have changed our protocol to admit all patients, all admitted patients should be subjected to COVID test on a routine basis. So that was
Dr. Srikanth, sorry to interrupt. We will not go on a COVID. Somehow we will try to restrict ourselves to the non-COVID, because I mentioned I'm concerned with the non-COVID of equally with the COVID. So what is forget about these 2 months? What you are observing before March or before February in last 1 year? What was the pattern of the resistant pattern in your surgical ICUs, and how much was a gram positive, how much was a gram negative, and
actually, sir, the thing of resistance has developed more into gram negative field than into gram positive. And I do practice in surgical oncology, as well as I am into general surgery. I am a faculty here at a government medical college in Odisha. So I am attached to a unit that is more of dealing with diabetic foot infections. So I deal with diabetic foot infections with sepsis, like skin and soft tissue. That's the worst form that can be diabetic foot infections with necrotizing fasciitis, as well as I do this hepatobiliary surgeries and other forms of oncologic surgeries. So I have seen both the things. In the skin and soft tissue part, I would like to highlight, if a patient is coming with Staph aureus resistance pattern, so previously we were using vancomycin or teicoplanin or something sort of. So now with the advent of Arbekacin, initially I was pretty unsure whether I will use Arbekacin empirically or I will get an antibiotic sensitivity. From the very first day, when I didn't have that antibiotic sensitivity also, I just tried as a drug that it is MRSA, it can be used in MRSA like pathogens. So I tried of my own and I got my results good. Then later the sensitivity tests they have arrived and we could do some sensitivity tests. Apart from my routine use in diabetic foot infections with Staph aureus, I use if a patient in biliary sepsis or cholangitis. So if the blood culture comes out to be some gram positive cocci, if the gram positive cocci, I suspect it whether it is some enterococcus or some Staph aureus or any other cocci, streptococci or something. So because Arbekacin has a very good gram negative as well as gram positive spectrum, so I started giving them. Some cases I have used on a single drug therapy and some cases in combination.
Okay. Thanks, Doctor, for the elaborative your practice. The next is Dr. Amitabh Saha. Dr. Apurva is probably not joining because of some emergency. How would you place in your experience in so many years in critical care areas, what pattern you have observed? Which are the systems which are more involved with the MDR? Which are the systems involved, like VAPs are more of the MDR, or intraabdominal sepsis, or CNS, or skin and soft tissue issue? So I will place overall your experience regarding MDR scenario or common MDR scenario in your day-to-day practice. Dr. Apurva.
The thing is,
sorry, Apurva is not there.
Right.
Yeah.
Basically, as we are all working in a tertiary care hospitals, in tertiary care hospital, and all our units are basically old. So all these scenarios, what my experience with the MDR bacteria is, most of the time we are getting the Klebsiella. Most of the time in the winter scenarios, we are getting the Acinetobacter, and to some extent the Pseudomonas. But these MDR and the XDR, especially the MDR, basically the Klebsiella is taking the first place. And regarding the CNS, CS, most of the time in our NICU, we are getting more of Acinetobacter rather than the Klebsiella. So this is the scenarios where in our general ITU is a slightly different bacteriological scenario.
And what about the MRSA? What about the MRSA?
The MRSA, yes, the MRSA we are getting around staff, if we get around in our hospitals around 10-20% of that 10-20% MRSA is hovering around 40%.
Okay, and in MRSA, whether it's VAP is more common, or intraabdominal sepsis, or skin and skin related?
No, it is actually the skin soft tissue and the VAP. It is mostly the skin soft tissues and the VAP.
Dr. Vasan Nagwekar, would you like to add regarding the presentation of MDR across India or in Western region? What is your experiences as an ID specialist?
I think the most predominant organism across India is predominantly everybody's problem is Klebsiella MDR, and usually it is predominantly colistin sensitive to the tune of almost 95%. There are some hospitals which have Acinetobacters also in their hospital. So it depends upon every hospital, every ICU, which it depends upon the flora of that hospital. So I think the epidemiological flora is very, very important. So, but I would believe that predominantly everybody's enemy as of now is Klebsiella, and usually it is, as I said, 95% sensitive. And when it comes to Acinetobacter, it is almost to the tune of that. It is majority of the hospitals. If it's a hospital-acquired flora, then you'll have almost 90 to 100% carbapenem resistant usually. We hardly see. At some time you might see imipenem sensitive. But usually it is colistin sensitive. It is fairly, tigecycline would be around 50 to 60% sensitive. Minocycline, I would say 30 to 40% sensitivity about Acinetobacter. So maybe Arbekacin, I'm looking forward, because at times we are just left out with no antibiotics, and we have seen patients dying because of Acinetobacters. So I think if we'll look into this Arbekacin in the whatever E-strips and see whether the sensitivity, only the breakpoints have to be defined. What is the breakpoints of this? Coming to Klebsiella, I think as Dr. Kapil has already said, if it's a community-acquired Klebsiella, then it is 70 to 80% is ESBL. But if it's a hospital-acquired Klebsiella, then believe me, it is almost 90 to 100% carbapenem resistant. It will usually be colistin. Phospho would be around, varying from hospital to hospital, 40 to 60% sensitive. And your trimethoprim sulfamethoxazole will be around 20%. E. coli is usually community acquired, or if it's a hospital acquired organism, then usually colistin is almost to the tune of 98, 90%, 99% sensitive. Phospho is almost to the tune of 98 to 100% sensitive for E. coli, and TG is also 60 to 70%. So that's what is the normal flora across India, and I think it is the same throughout. But some hospitals will have Acinetobacters. Some hospitals will not have Acinetobacters at all. Those hospitals who have Acinetobacter have poor infection control practices. Those hospitals who do not have Acinetobacters have a good infection practice.
Yeah, rightly said. During your presentation, you said regarding how we'll go for 4 and 5 points regarding vasopressin and those who are in the sepsis management. But see, what you rightly mentioned, that it is simultaneously. It is not like that I will go ahead with the fluid, then I will optimize, and then I will add. Sometimes if the BP is 60, I need to start the noradrenaline and if you got vasopressin and simultaneously, because fluid challenge is not like a flu bolus is within 5 minutes. It will go over half an hour, 1 hour, 2 hours, or 5 hours. So for theoretical purpose, it's fine on paper or writing something. You can have a 1, 2, 3, 4 point. But in practice, might be I will start with the 5 first, then 4, then 1, then 2. So it's not the meticulous follow-up of that particular number. It is just to give the idea that you are not missing from the checklist.
So you are telling mostly a surgeon's perspective, sir. Surgeons go in that way.
So that is the purpose of involving you also. We will learn from something you, as well as you will learn from something else.
Team approach. It is always a team approach. The whole team has to do the all 5 together.
Yeah, so sepsis is not like that. Septic shock patients are not going to give you time. You need to work simultaneously. You need to add everything. I told you now, might be I will start with the Norden, the stateway, and then fluid challenge, simultaneously push the fluids, and then send the blood cultures there. So it will go like that anytime. But of course, the preference will be the as early as possible antibiotic. What you rightly, very, very one of the good point is that forget about the 3 hours and 6 hours. Now come back to the 1 hour. And not 1 hour also, as early as possible. If suppose a patient is with me and in my unit there is a drug is available, I'll even push it within 20 minutes or within 10 minutes also. So as early as possible is the right word. And for the sake of understanding 1 hour, 3 hour, 5 hour, might be they will come up with the 30 minutes after a few months. So it's on. So that is the one. Second point regarding the culture pattern, it changed from ICU to ICU, I agree. Like in my Ruby, we have the 5 buildings. We have the 2 critical cares in the 2 separate buildings. And when I followed that, fortunately, I'm a director of the both unit, but the teams are different for the both this thing. And when I go on to the culture sensitive pattern, in one team, one ICU, I'm following the Acinetobacter 60-70%. Another thing, it is 80-90%. One ICU, I find the minocycline is more sensitive rather than the meropenem. Meropenem is almost resistant in others. So this type of I think that's what you rightly said is what type of the infection control measures you are taking, how aggressive you are with that. Surface cleaning and those things will definitely make the Acinetobacter different. And secondly, how meticulously you follow your culture pattern. That is the bottom line for this MDRs. So coming back to the again clinical discussion, Amitabh, what will be your management line of the management for the gram-positive infection? Now we'll come back to the again gram-positive because we talk a lot about and everybody talk a lot about the Acinetobacter and Klebsiella. Dr. Amitabh Saha, you are around? Yeah. So will you please just give us a brief about what is your line of management for the gram-positive infection in your ICUs, whether it is VAP or whether it is intraabdominal sepsis or anything.
Are you asking for the VAP?
Yeah. No, I am asking overall. Suppose the patient is a septic shock patient comes to your ICU. So you are strongly suspecting it is a gram-positive is likely. So in such situation, what line of treatment or in a proven MRS also?
Right. If we think of any patients who is suffering from a gram-positive septic shock, most of the time still we use the ticoplanin. Followed by vancomycin. We never use the linezolid. But if we look at the patient is not in shock, the patient is primarily having the pulmonary involvement. Many a times we use the linezolid. But the thing is, if the patient is really shocked, we use the ticoplanin in a dose of 400 milligram thrice in an initial dose to only, then apart from 400 milligram and adjust according to the renal clearance. But again, as we know that the ticoplanin doesn't have really a draft level, or we really do not have any idea how rapidly or how effectively it reaches the draft level so that it can fight against the gram-positive. But again, we still use the ticoplanin, and we are actually thinking of after getting a lot of information and the evidence and also the experience of using Arbekacin. Maybe we probably use this Arbekacin more and more in this scenario.
Coming back to Dr. Nagrekar. Dr. Nagrekar, how will you place Arbekacin in this current scenario on gram-positive infection? Would you like to go ahead with the empirically, or you would wait for the E-strip, or you will straightway first initially start with the another anti-MRSA and then introduce the Arbekacin?
Then I think I will, if it's a skin and soft tissue infection, which I'm looking at, basically community acquired. So both Leelavati and Global Hospital, where I'm practicing, both these tertiary care centers, we don't have in-house MRSA infection. So we don't have a hospital acquired MRSA infection. So whatever patients come to us from the community are either methicillin sensitive Staph aureus or it is MRSA skin and soft tissue infection, usually paravertebral abscesses and all that. So I think as of now, I would go with possibly either daptomycin or ticoplanin, because daptomycin is very good for skin and soft tissue. Or I would use Vanco is average for skin and soft tissue. Linezolid is good, and or even ticoplanin to around 6 to 8 milligram per kg per year. So coming to Arbekacin, I would wait for the E-strip. This thing I don't have, I'll wait for the sensitivity of that and then only do it. But I'm looking more for Arbekacin for my Acinetobacter problem, which I'm devoid of antibiotics.
Yeah, but sometimes, Dr. Nagwekar, we are always wonder, in ICU we don't get time. If it is septic shock or it's impending multi-organ failure, in such critical care situation, whether it is even come back to the empirical choice, would you like to start Arbekacin? It's because see, one of the beauty of Arbekacin is it not only covers MRSA, it is very potent MRSA. And if my clinical diagnosis is 70% MRSA and 30% gram negative, so it may cover your Acinetobacter and E. coli in certain. So is it possible to have a combination of, I will come to that combination question later on, but what you will put in the Arbekacin in an empirical scenario? And that is one of the questions asked by one of the attendees also.
I would possibly use, if at all you have to use either Tico or, ticoplanin or daptomycin along with Arbekacin rather than using Vanco and Arbekacin, because Vanco is nephrotoxic, so I don't want to use two drugs which can be effective. So I would prefer to use, if at all, daptomycin or ticoplanin along with Arbekacin.
Yeah, but you find place of the Arbekacin in empirical? Because it is always dilemma whenever we are.
I said I would wait for the E-strips and only my microbiologist gives me the answer only then. But as of now, I would use either Tico, Vanco or your linezolid or daptomycin to be for skin and soft tissue, or for a gram-positive coverage in the ICU. And upfront, I wouldn't, because I would wait for the microbiologist to tell me about the sensitivity of Arbekacin to be used. Only I think when we have more and more E-strip reports about various MRSAs, the sensitivity pattern for Arbekacin, and I think they already have it, so maybe then subsequent I would.
Yeah, and a few of the reports also there, if we combine it with the carbapenem or erythronow. So when there is a mixed infection, we are not sure. So would you like to start the Arbekacin with the azithromycin or with the carbapenem to start with and get the E-strip and the rest of the things when patient comes from the other hospital? See, what you said is right. If in your hospital, it will be quite easy for you to take a decision. If somebody comes from the outside, which already he received some antibiotic. So in such scenario, what will be your expenses?
So the most likely cause of a patient, so there's a recently paper which is published by me only, which talks about patients coming from other primary and secondary healthcare centers and coming to a tertiary care center. This was in Fortis Mullen, and we found out that the gram-negative bacteremia was the predominant cause of all the problems which they came from primary and secondary healthcare centers. So here, possibly I would go, if the patient has come from another hospital, I would send 2 sets of blood culture. Upfront use colistin or polymyxin based therapy there, along with a carbapenem, high dose carbapenem, and wait for my cultures to come back. Arbekacin, I would wait for my microbiologist to tell me about sensitivity to MDR, Klebsiella, or E. coli, or Acinetobacter, and then I would start using it.
Amitabh, you'd like to add anything with your experience regarding the combination therapy or empirical therapy?
Yeah, empirical, I would still skeptical to use empirically as of now. I would like to use Arbekacin based on the E-strip reports. But yes, combinations, probably it would be better to use the Arbekacin along with the combinations of other that ampicillin sulbactam, or in case of gram-positive, would be the vancomycin or the daptomycin, what Dr. Basant has said. But daptomycin has probably one of the antibacterial gram-positive, which is more strengthened than the arbicacins if we compare with all the antibiotics. So yes, it's a combinations where we can use the arbicacin judiciously, where we cover the both gram-positive and negative. But definitely, still we need to check the history reports before using things. Empirically, yes, we can use, but when the patient is in septic shock, probably arbitration has not come into that stage, or we can use other arbitration in septic shock state as the empirical antibiotic.
What dose you are using, and how maximum days have you used the arbicacin? And
Arbicacin we have used the maximum of
2-3 reports simultaneously. 2 questions.
Yeah, the last patient we have used the arbicacin about 14 days for the abdominal sepsis patient, and we have used 200 milligram per day.
Any side effects you have come across?
Not really. Rather than basically when we start with the arbicacin, the creatinine clearance was pretty low, but after having correction of the sepsis, all the organ function has improved. It's not the arbicacin, it's that basically sepsis has improved, the organ has improved.
Okay, Dr. Shrikant. Dr. Shrikant is around.
Yeah. Tell me, sir.
Yeah. Will you please?
I would like to refer to the
you are aware about this molecule. Have you used in your surgical patients in either general surgery or?
As I have started my practice empirically using.
Experiences about this molecule.
Actually, sir, I have started using this molecule on an empirical basis, going through the literatures only. I would be differing with the critical care people around here. So actually, when it is a surgeon's perspective, when the BP is going down, when the patient is in sepsis, I would like to intervene with multiple things. If the patient is improving, then I like to de-escalate. That was my way of doing the things. Dealing as surgical, this septic shock sort of thing. So I use this with combination, with single, as well as like in diabetic foot infections, specifically necrotizing societies, in empirical basis also. I have started using it empirical basis, and I have got good results to that.
But it's a monotherapy combination.
Some cases in monoproduct as well as some in combination.
Okay. So with this, Dr. Nagvekar, you are around?
Yeah, I'm around.
Yeah, see, your topic was quite broad, and it's your specialty, it's very core specialty of the septic shock and this thing. So you have mentioned regarding the severity of the Q-SOFA and other thing. So if suppose there is a septic shock patient, whether you would like to follow with the lactate or procalcitonin?
So I think procalcitonin has been studied best to when do you want to de-escalate your therapy. Procalcitonin is never used for diagnostic purpose. So I think I would go clinically. The patient has come to you with sepsis, septic shock. If there is a syndromic diagnosis, I will not bother about the procalcitonin. I would straight away go and treat it as sepsis, septic shock. And lactates will help me to tell me whether the patient is getting better every hourly or 2 hourly because with your EVG machine. And I think that will tell me the clinical, how the patient is behaving. Procalcitonin, whether it comes 2 or 4, will not tell me whether the patient is getting better. I think lactates will definitely guide me whether how the patient is behaving, and that will make me more comfortable.
Yeah, but about the Q-SOFA, it is the predictor of mortality. It is not for diagnostic in sepsis.
I'm not saying that lactate will help me to diagnose sepsis, and Q-SOFA doesn't diagnose sepsis at all. I'm saying for follow-up patients of sepsis with septic shock, those who have come with septic shock, a lactate which is very high, say it is, there are various, some labs have 2 as a cutoff, and some of the EVG machines which have 20 milligram per deciliter as cutoff. Yeah. So if suppose this patient had 6 as lactate when he came, and he was hypotensive after resuscitating and after starting your inotropes, and after pushing in your antibiotic therapy, if you repeat his lactate say after 8 or 12 hours, and if your lactate has started coming down, that will make me more comfortable that the patient is getting better. Procalcitonin is, I think I wouldn't use procalcitonin to diagnose my clinical judgment. I would straight away go ahead and try to find out where is the source of sepsis, and that is not going to really guide me. If at all, if I have done a procalcitonin, then I will use that as a baseline. Suppose if the procalcitonin is 20, then I will use that as a baseline 20 to later on 7 days, 10 days when to stop my therapy. Once it comes below 0.5, I know that I have to stop. but not as a diagnostic tool.
Yeah, you rightly say that 80% of the drop from the baseline might be, you can consider if there is a clinical improvement associated, you can de-escalate your antibiotic. But again, in MDR, when you are treating the MDR hospital-acquired infection, how much you believe on a de-escalation, whether it is a discontinuation or de-escalation?
No, so if my organism comes as sensitive, okay, then definitely we will de-escalate according to the flora what is there. But I believe me, once it's a hospital-acquired infection, whether it's Acinetobacter, whether it's a Klebsiella, or whether it's E. coli, I don't think you can get out of polymyxin-based therapy. So that is tough. Maybe you will have to alter the other antibiotics. But yes, if the organism comes as sensitive, I would be boldly going and de-escalating, definitely.
I think that's the point. That's the point. When you are talking about the MDR and resistance to all and only sensitive to tigecycline and colistin, what to de-escalate? Either you have to discontinue after 7 days or 10 days or 14 days. But rather than putting them on a BLIs, will not solve purpose. That's what my always point in hospital-acquired infection.
No, only if it is sensitive, then you de-escalate. But just if it is not sensitive, there's no question of de-escalating. You'll have to continue with combination therapy. And tigecycline, colistin, maybe for high-dose tigecycline for Acinetobacter VAP or whatever, or for intra-abdominal infections, E. coli, Klebsiella. Sometimes your 50% of the organism would be sensitive to tigecycline. So in that, I would use it for 10 days and then straight away stop it after 10 days. I wouldn't stop 1 or 2. I would continue that for 10 days and then only stop at 10 days.
Yeah.
Normally, Dr. Narvekar, normally in these scenarios, would you like to continue the antibiotic for 10 days or 14 days?
10 to 14 days, that's what I'm saying. 10 days, early would be 10 days, but maximum would be 14 days. Yeah. But if the patient quickly gets better in, say, 48 hours time, if the patient clinically gets quickly better in 48 hours time, I wouldn't hesitate to stop at 10 days at all.
Yeah, though we say a lot that we should not discuss the COVID. Without COVID, we cannot end any discussion. So now, being a Mumbai, you know that the hotspot of the Mumbai, and it's being a viral infection. We are using a lot of immunomodulators. You are using the steroids. So what type of they must be after 10, 12 days, these patients are going to acquire the hospital-acquired infection. I am quite sure isolation ICUs and ward will not get spared. So I have came across recently very few patients who acquired the secondary infection. Generally, what they say on tocilizumab, the chances of the aspergillosis or fungal infection will be more. But that is one thing. What is your experience? Have you came across the MDR infections in these COVID patients who are on?
Yeah, Dr. COVID, basically, we are managing a good amount of COVID patients in our hospitals. We have almost 132 beds of COVID. So initial 2-3 months back, we really didn't get a lot of gram-negative infection. Basically, the infection was not at all there. But nowadays, we are getting the patients who are on ventilator for at least 10-8 days. We are now getting more and more MDR Klebsiella. Klebsiella has come into a picture. Because there are two things that we have seen in the COVID area where it is happening. The people are on PPE. They are protecting themselves, but they are many a times forgetting to protect the patient, because they are already on 2 gloves. So whenever they are doing some procedures, they sometimes forget to get another fresh glove. So it may be one reason. Probably the hand hygiene is not maintaining inside the ward. It could not be as well probably in these scenarios. So probably in the unit where our unit is getting older than 4-5 months, now we are getting more gram-negative bacteria, and all to some extent the MDR bacteria also we are getting, especially the Klebsiella. For last 4-5 patients, we're getting the MDR Klebsiella.
Dr. Vasant Narvekar?
Yeah. So I think I agree with Dr. Amitabh Saha that infection control practices have gone a toss in the COVID ICUs because the infection control practices are not that good when they're handling the lines and all that. They really do not use hand hygiene so frequently because they're already fully PPE and double gloves. They don't make the use of using hand rub or using another gloves before they handle the lines. And I think that is the major reason why there is a lot of patients who get a bacteremia. But I'll tell you, those patients who have received tocilizumab, you have to be careful because many of them are developing, bloodstream infections depending on the local flora. So I've seen Acinetobacter MDROs, I've seen community-acquired Klebsiella and E. coli is also in the beginning of those patients, maybe translocating from the gut possibly, And I also see the MDR. We just had a patient who was 82 years old and he had received TOSI, but he recovered very well. But then he went to the ward, he was doing fine, sudden and hemodynamic instability. Luckily, we gave him colistin, minocycline, and then he survived, but his blood culture growing Klebsiella MDRO, which is sensitive only to colistin. So we are seeing MDRO bugs and also sensitive bugs, ESBL, but those patients, especially those patients who are receiving tocilizumab, I think that is one thing we have to rely. We are trying to avoid central lines as much as possible in these people. But if you're using a HFNC high flow nasal cannula or humidified oxygen, then these are the patients who you would watch for developing HAP or VAP.
On the other way around, what you say that there are limitations of the isolation ICU is that infection control policies are not that much high. Other way around, do you think because of the less traffic, less interventions, all are in a PPE, whether there is a infection rates are low as compared to the, even see these all patients are from day one on steroids. They receive tocilizumab. They are severe viral infection. They must be the severely immunocompromised. So what percent, whether you find it is a less percentage in the COVID areas against the non-COVID areas?
Yeah, it is much less compared to what my medical intensive care unit was during the non-COVID era. It is lesser because these patients are usually either on NRBM or high flow nasal cannula or NIV. They don't have invasive lines. They don't have Foley's catheter. So all those, the CLAPSI and COTI part is out. Even they are, as far as possible, we try not intubating them. But once you intubate, then yes, of course, you can expect anything. So at least two major syndromes are out. That is COTI and CLAPSIs are out. So what leaves you behind is only patients ventilated, usually developing VAP. But yes, you have to be careful with those patients receiving tocilizumab. They can develop bacterias.
Yeah, and what you rightly mentioned is that you need to have if you are wearing gloves, that doesn't mean that you are sterile. You have to wash you have to use the hand rub over the gloves also. What we are hand washing. Or change the gloves, or change the second gloves. What I always advise, if you are wearing the two gloves in between the patient, in between the procedures, in between the everywhere, if possible, it's a huge cost factor. Change that gloves if you are at least handling the center line, and do the hand rub. Even on gloves, you can use the hand rub. It is not contraindicated. But what you rightly mentioned that because of the less intervention, that's what my point. Less intervention, less traffic. Nobody's there to enter in the isolation ward, and because of the less this thing, we have less infection rates.
Yes,
so that might be the surviving factor for this poorly COVID patient. Okay, so with this, I would like to conclude this interesting session. I also learned a few points from out of this. Yes, we are getting a lot of Acinetobacter. Being a neurotrauma unit, what you rightly said, we have a huge experience of the Acinetobacter as well as the MRSA being a neurotrauma unit. And infection control policies are the bottom line. At the end of the day, you have to just concentrate on your surface cleaning, your hand hygiene, your shadow observers which are following your staff continuously, whether they follow the infection control policies, your judicious use of the antibiotic. Avoid the empirical use of the higher antibiotic unless and until it is indicated. As early as possible, de-escalate your antibiotic. And the most important thing, follow your trends. What we are doing the every month departmental meeting to follow what are the trends of our MDR infections and which are the antibiotic sensitivity and consistency pattern, and accordingly make certain changes, whether you are overdoing or you are underdoing, accordingly execute. So with your sister in charges, your your infection control nurse, ID specialists, and we all sit together, not in COVID areas prior to that till March, and we are trying to learn our own practice as well as the MDR pattern and your antibiotic use. I think that's the best thing we can do it, whether you are in a COVID or non-COVID area, whether you are intensivist or non-intensivist. And whenever necessary, please don't avoid to take the opinion of the ID specialist that I always mention in every this thing. With this positive note, I hand over to back to the team, Alkem team, and stay safe, stay cool, keep your mental peace in control, and follow the all infection control policies. Whether I always say that this COVID taught us a lot many things. COVID taught us a discipline. COVID taught us the importance of the hand hygiene. COVID taught us what is the value of the each and every soul or the human being. And we should not take it as a only negative this COVID. We learn a lot out of this pandemic. We are learning and hope so soon it will be coming under control in India. Thank you. Thank you to the Dr. Nagwekar. Thanks to Dr. Amitabh Saha. Thank you to Dr. Srikanth. And
thank you. Thank you, everyone.
Thank you.
Thank you, sir.
Thanks,
Thank you.
Kapil. Thanks, Amitabh. Nice meeting you, and Dr. Patro.
Thank you.
Thank you, sir.
I think Sandeep.
I would like to just put my vote of thanks to all of you, Dr. Kapil Jirpe, to conduct this meeting without any flaws, and a lot of thanks to Dr. Basant, Dr. Srikanth, and Dr. Amitabh Saha for their contribution and for their knowledge sharing. I believe the overall message has gone very positively to all the doctors who has attended, and we will definitely take this video on to some more intensivist physicians who could not attend it. Thanks a lot for you. Before we close that, just I will bother all of you as because I got all of you here again. So in this scenario, how do you see remdesivir use can give the benefit to the patient, COVID patient? Just 5 minutes from all of you.
We'll start with the Dr. Nagwekar. Being an ID this thing, you will highlight because you are the one who had the maximum patients during this pandemic. Sir.
So I think remdesivir has been quite promising, and it definitely is it definitely helps to the patients to get better. But very important is that you have to time it correctly, and you have to start as early as possible. Just like oseltamivir, how do we start for H1N1? Of course, the trial in the NECROTISING, they said that once the patient becomes hypoxic, then you start. I have a slightly different opinion that once the fever is not subsiding beyond 3 to 5 days before the patient becomes hypoxic, we should be using, but the guidelines do not permit us that. But remdesivir is very, very promising in the era of COVID-19. I can tell you that.
Dr. Amitabh?
The remdesivir, yes, we are using remdesivir as and when it is available. But again, I agree with Dr. Basant that the uses of remdesivir has to be very judicious, because in a very sick patient, remdesivir doesn't probably improve the outcome. So the remdesivir, we need to catch up the patients who is a mildly severe or just going to a more severe form. So what we practice in our unit is whenever the patient is going to a NRBM or the patient going from the nasal cannula 4 liters to 6 liters to NRBM, then probably then this group of patients we are using remdesivir, and basically with the use of remdesivir we have got actually a good result along with the steroid. All the patients on steroid get on oxygen getting steroid along with the remdesivir. This mild to moderate group of patients, they are showing a very good results. But yes, the patients if already on BiPAP or ventilator, remdesivir probably doesn't give a very good result.
Yeah, I agree with Dr. Vasana as well as Dr. Amitabh. Remdesivir seems to be promising. With my experience also, we have used almost in 100 cases till now. Second thing, I am using in moderate to severe cases. No doubt we should use in moderate to severe, but other way around, what Dr. Nagwekar said, in early phase, what we are doing, trying to do the HRCT in each and every patients who are on initial oxygen therapy, like 4 liter or on mask. And if the GGOs are more than 50% or they are worsening as compared to the previous HRCTs available, I'm preferring the remdesivir. My view is rather than patient going on an NIV and high flow and ventilator, we can use this prominent antiviral therapy to prevent them onto the non-invasive or invasive ventilator. And that is working quite nicely, but this is my personal experience. I don't want to push my decision as a changing practice. But yes, remdesivir seems to be promising in current scenario when there is very few antivirals are proven to be effective.
One thing that the paper and the remdesivir, the clinical that has actually been done, the remdesivir doesn't improve the outcome, the mortality outcome. It only increases the viral clearance early. So we need to understand whether the increased viral load, whether it is going to a cytokine storm. So if it is so, then probably remdesivir works in the mild and what actually which is working.
I think timing of remdesivir makes the major change in the prognosis. Timing, when you are introducing the remdesivir to that particular patient, that will give you the change in the outcome.
Okay, that's great. So just last question and then we'll close. So approximately 20-25% patient active patients are the potential patients for remdesivir today. Just a hunch, just a number.
It is very, see, this is not so straightforward 25-30%. It depends on the what type of the hospital is there, what type of the patients. It depends on the case mix. Might be the corona care facility or only corona care initial patient asymptomatic mild cases. There might be nobody will use the remdesivir. But on the other hand, there are those patients who are requiring the more or more oxygen therapy, those who require the high flow, non-invasive ventilators. So might be remdesivir used in one institute will be the peak, while with the other institute will not be there. So it is nothing to do with the percentage. It is to do with the what case mix is there and how severe or what type of the patients you are getting. It's not the Ramban something like on every patient you should use. That's what the breaking news are spoiling the whole purpose of such antivirals. It is not like that. One should not promote, because what will happen, it will, when the deserving patient needs, it will not be available. And that is what the current situation.
Yeah. Thank you, sir.
All depends on what level of care basically we are thinking of. If it is a level 1, level 2, probably the patient doesn't need any remdesivir support. But in level 3,
patient comes with the prescription of the remdesivir and with the this thing. That is not done. That is not acceptable.
Exactly. In level 3, level 4, there may be a patients who may need remdesivir.
Thank you very much. Thanks once again to all of you. Thanks for coming, and then we'll be in touch with you. And once again, my sincere thanks to all of you, sir.
Thank you.
Thank you. Thank you very much.
Good night. Good night.